And with that, it's my great pleasure and honor to introduce Dr. Humayun Bashir, who is a consultant in nuclear medicine at East Kent Hospitals, University NHS Foundation Trust in Canterbury in UK. Dr. Humayun Bashir is a fellow of College of Physicians and Surgeons, Pakistan. He's a fellow of European Board of Nuclear Medicine, and he's also a fellow of Royal College of Physicians, Edinburgh. He serves on the committees of European Boards of Nuclear Medicine, British Nuclear Medicine Society, and also on the American College of Nuclear Medicine. Without further ado, Dr. Humayun.
Thank you very much, Simon. It's a privilege and pleasure to be on this forum. It's such an exciting forum of senior faculty as well as some junior members from all over the world, I hope. So I'll just share my slides. I hope it goes smooth. You can all see my slide?
You can put it on the slide mode, Dr. Humayun.
Okay. Is it right now?
Yes, perfect.
Okay, great. So thank you for the invitation once again. Today I'll be talking about bone scintigraphy for assessing fracture risk in patients with bone metastasis, a road less traveled. I call it a road less traveled while, bones imaging, bone scintigraphy is the workhorse of nuclear medicine all over the world, because this particular aspect I feel is that something which we can explore. I have no conflicts of interest to declare. The learning objectives will be, we briefly go through the pathophysiology of bone metastasis, fracture risk assessments, how it is done at the moment, and what bone scintigraphy can offer. Now, whenever you have to have some new ideas, it's always good to read old books. So back in 1889, Stephen Paget sort of recognized that breast cancer has a sort of tendency to metastasize to bone. So this whole cancer, of course, was always a very aggressive disease, studied and treated by physicians. With this concept of cancer spreading into bones, this is this report in Lancet from 1889. We talked about secondary growth in the cancer of the breast cancer in the bones, and we started from there because we're talking about metastasis and the fracture risk. Now, this whole concept, over the 100 years, more than 100 years, a lot has changed and developed in the understanding of how cancers are develop and they spread. Vis-a-vis the metastasis, there was this recent paper in, not recent, already 20 years now, revisiting the seed and soil theory of the bone metastasis. Also, all the new developments actually were leading to the same old concept that there's seeding inside the bones. A brief schematic diagram. You see the steps involved that from the tumor site, tumor cells kind of detach, then they make their way into the vascular system. Within the vascular space, they find some friendly friends who make sure that they don't get destroyed or entrapped. There's these friends actually take them to the other end, and while the metastasis can be seen in liver and lungs, bones are the third most common place, and at the site of the along the vascular supply to the bones, there are exit gates. These are complex systems through which actually these tumor cells are able to go out of the vascular system and then seed into the bony structures. Within the bone, it's a very complex, it's yet another multi-complex system. These tumor cells attach with the bony microstructure. Then there's osteoblastic and osteoclastic activity. There's, there are mechanisms which actually destroy the existing bone, and at the same time, there's reconstruction of bone going along. All in all, the balance is more towards destruction of the particular spot of the environment within the bone, and leading to spread and really advanced stage malignancy. All these various steps now, as we live in the molecular age, which is diagnostics and therapeutics as well. All these steps in the progress of a tumor, so-called ambulus, from the primary site to the bones, offer various molecules which can become therapeutic options. And so we are currently living in this age that all these steps are being studied thoroughly, and treatment strategies and treatment um, drugs and other stuff is being organized around these paths. And in the same battery of things now, radionuclide therapy is also there, but that's not the focus of our talk today. So anyway, that's again just showing you a similar schematic diagram in which there's osteoclastic and osteoblastic activity within the bones, and different various pathways which are disrupted actually provide us with opportunity for developing treatment options. Now here I put these two editorials. One is from 2007 and the other is from 2018, so 11 years apart. Dr. Alavi's name actually is visible on both. Now, from the previous few slides, we just saw that the tumor thrombus actually settles on in the bone environment, and that's how metastasis develop. Mr. Alavi has actually written two of these editorials, emphasizing both 11 years apart, that we have to remember that the tumor metastasizes to the marrow, not the bone directly. The changes that we study along the bone are secondary, but primarily the tumor thrombus actually lands into the marrow, and which further leads to disease. So we have to remember this thing, because these two editorials are very interesting to read, because what happens is that, as we do bone scans, and the most common indication is looking for metastasis. So we see, bone scans pick up metastasis, but for most of the malignancies, bone imaging is actually picking the secondary impact of metastasis, because it's be looking at the cortical changes, which actually our tracers go and capture, not what is happening in the marrow, unless we are dealing with traces like FDG and more specific traces. So with these editorials, Dr. Alavi and his team sort of remind us that keep the focus. Every new tracer doesn't say, when you see a new tracer which is giving you better mapping of the metastasis than bone scan, so it's not a straightforward thing that this particular tracer is better than HTP. No, this particular, say, for example, FTG is looking at the primary site of disease, while bone scan was looking at the secondary. So it's not a very good comparison to knock out bone tracer imaging in that sense. And that's, we'll see how it relates with our current presentation. Going back again, this is paper from 1917. This is a good one in a sense. I put it here because it talks about metastasis to the skeleton. And then this is probably the first paper which mentions about the use of X-ray to evaluate bone metastasis. In the process of this search, I actually came across the first X-ray report as well, which I have not put here anyway. But the idea was that since the metastasis, tumors, cancers metastasize to bone, and probably X-ray should be an important part of this workup in advanced cases, if not this day. So that's how we know this mechanism of staging the cancer and the involvement of radiological imaging into it. We can trace it back to this time. This is a review article looking at the imaging for diagnosis of metastatic bone disease. And here you can see that on the list, we can see X-ray, CT, SPECT CT, MR, PET CT, up to PET MR. And there are different, each modality is looking at different aspect of the bone status. So at morphology, and then metabolism is studied through the nuclear medicine imaging, marrow involvement directly through nuclear medicine as well as MR, and of course PET MR is a combination. And then there are diffusion studies as well. Let me just, yeah. And of course, glucose metabolism is studied through FTG. In this review, you can see that on the left side, we have got different malignancies, all the common ones, and up to the melanoma, basically focusing on men. And then, yes, of course, we've got women on the lower down with breast, bowel. And you can see that marrow involvement is seen in all metastases, while in prostate, there's more involvement of bone as compared to the lung and bowel, which are more lytic lesions. So some are mixed, but marrow involvement is the fundamental, and this goes back to what from where we started initially and what we saw in the editorials from Dr. Alavi and team, that is fundamentally metastasis is involvement of the marrow. Now, with bone metastasis, we're looking at advanced stage disease. It can be unifocal, it's mostly multifocal. It completely changes the scenario for treatment. It has an impact on the outcome, survival of the patient. So in this process, while it's a systemic disease and is being addressed through systemic treatment and various options, one of the things is to assess for fracture risk in the bone metastasis, because then that adds to the complication of having malignancy in the first place. And with improvement in survival, even with advanced stages of disease, as more and more treatment options are coming up, the capacity to identify advanced disease like skeletal metastasis and to make sure they do not worsen the situation by getting into getting fractured. So that's where the assessment tools come in. Now, one of the fundamental things which nuclear medicine offers as compared to other things is actually the mapping the metastatic layout, the disease, which, it's like same to drawing, the science of drawing maps, it's called cartography. So with our whole body scans and bone scans or even PET, we are able to identify the spread of the disease. One lesion might be presenting as a symptom while there's more. So fundamentally, one thing that nuclear medicine offers as compared to other things, and the same process, we don't, basically with newer, faster cameras, you can image the whole body quite quickly. But if you have to do a CT or MR of the whole body, that's that involves more radiation. While in a bone scan without the CT component, we're able to scan the whole body with reasonable, calculable radiation dose. Now, with fracture risk assessment, now I'll go through some review articles which have been published in the last 5 years, and which actually got my focus onto the subject that we are discussing today. The fracture risk assessment is a burning issue. These are papers mostly coming from orthopedics and urology, and basically the database of physicians who are referring physicians for the imaging services. So this is a burning issue. The mechanism of pathophysiology of bone metastasis is one aspect, and then how bones respond to it is the other aspect. So in this graph, you can see that there's a linear pattern where the bone can take a certain stress from normal physical activity. But if that bone is weakened, then it would give way to the normal physiological pressures, and then there's a pathway, there's a mechanism for that, and there's a pathway for that. There's an elastic domain of the strength of the bone, and then there's a plastic deformation, and finally the stress can take over and the bone can fracture. So these are the risk evaluations which the treating clinicians want to know, because if they would like to, they cannot go in and fix every metastasis. Firstly, they can be multiple. In the weight-bearing bones, that's the area of focus. But then again, they would like to identify the patients who would get the maximum benefit of it, with better survival with bone metastasis. Not every lesion certainly needs to be treated aggressively. So in this, here we have an example. On top row, we can see the multiple myeloma, which is predominantly lytic disease with almost negligible sclerosis around it. And you can see this whole lytic area in the T8 and T9 vertebra. In the second row, we have a urothelial cancer, which of course had a predominantly lytic lesion in the vertebral body, but with treatment, it has sort of sclerosed in the follow-up of 2 months and 4 months, and then disease recurs, so it again becomes a lytic process. So there's variations in pure lytic lesions, and then there are variation of response, presentation as well as response in different metastasis. And these are this just highlights the various factors involved in assessing the risk for fracture or more problematic destruction of a particular bone. Now, this diagram, picking from the same previous picture as well, you see there's a fracture risk initially. Metastasis that develop is predominantly destructive, and that's how it presented. It got identified because it was causing different signs and symptoms, pain and a problem in walking, say it's in the femur. And then when the cancer treatment starts, then essentially a phase in which the bone is still lytic. Then with treatment, success of treatment, bone healing starts, and later on there's a condensation and the bone becomes more solidified as a response to treatment, and then the risk of fracture changes. So it's a dynamic process. It has to be judged at what stage of disease, what intervention needs to be done. So it's a burning issue as far as the orthopedics and the referring clinicians or oncologists are concerned. Sorry?
Impacts within the body.
Yeah. Sorry, I couldn't hear you. Should I carry on?
Kindly please mute and
Okay. So this for fracture risk assessment, various scoring systems had been developed. For the long bones, because that's the main area of concern, the Myers scoring system was developed around, I can't remember the year now, but anyway, like late 70s, early 80s. And it talks about the site. We basically have 4 points into the system. One is the site of the metastatic lesion, then this composition as sclerotic or osteoblastic or osteolytic, and then its association with the kind of pain it is causing, and then size of the lesion as assessed on the X-ray, which from which we can judge the involvement. So it's, all these 4 points are scored from 1 to 3, and in the sum, if the score is from 0 to 7, it actually will be like 4 to 7. It will be low fracture, and if it's 9 to 12, then it's an impending fracture, and that's where clinicians have to go in and do something about it. 8 is the borderline area. We score around 8. This mild scoring system is applicable in the long bones, in the limbs, while there's a different system which is called SINS, applicable on the spine, which takes into account different because in the spine, there are different vertebrae have got different capacity, mobility, different sort of weight distribution. So those scoring system has got more constituent factors, and the adding up also goes up to 18. But basically, they have this stable, potentially unstable, and the unstable. Now, these testing systems have been around. These risk assessment systems have been around. They have been used, and they have their limitations. And that's what has actually brought up this article as well, that these systems exist. They have been tested in various setups. They are helpful given that they are the only available options. Now, are these from the previous two systems? There are a couple of other systems as well, but I've actually quoted the two most common ones. Now, from here, the next level of debate is, the reviewing these systems and all the data that's available about these, that what new tools can be, formulated from these systems or from newer modalities to have a better precision, better decision-making tools, to say. So firstly, as we have discussed so far, bone metastasis is a multifactorial problem. It's mechanical as well as non-mechanical features. So many things are at play, the primary disease and the treatment as well. It requires a multidisciplinary approach, patient, oncologist, radiation oncologist, surgeons, orthopods, and the imaging people have to be together. The options to look at these risk assessments have to be simple, which is sort of everybody can speak the same language. Complexity has to be on the easier side, and it has to be cost effective for application as well. So in review of this different risk factor assessment tools, the authors actually compared the Myers score, which is Myers score of greater than 9 has got high sensitivity. If it is positive, then of course it's it will pick up most of the fracture lesions with fracture. However, the specificity is quite low because so many factors are at play. And then they compare it with the axial circumferential. There's a Dutch group which looked at the axial involvement of the lesion is in the bone, and then the circumferential cortical involvement was also studied by another group. These are all features from the X-rays or at best CT, and they said that the specificity could be improved with the involvement of have a multidimensional X-rays or CT, while the specificity of Mirals was actually worse as compared to the other two options. The other two options of X-ray and CT, they looked at the lesion involvement lesser or greater than 30 mm, or if the involvement of the cortical thickness was more than 30%. So, different options coming up with X-ray and CT, but each one had its own challenges. Same three areas. In addition, they have come with this CT rigidity analysis, and then we had this finite element analysis as well. These are components which are looked on by the CT of the bones, CT's imaging of the bones. These are complex procedures. However, both are able to improve the where the specificity of actually Miral X-ray based scoring system was lacking. These two options of CTRA and element analysis actually have technological challenges, with them. And this paper is from 2021, and these challenges. This is another paper from 2021, same time, in which again this group also looked at all these Miral scoring system and the ACI, and they also added this FTG paper done by Dr. Ulner in US, and which actually showed that FTG had a very good specificity as well. Again, that has challenges because there are many other factors which actually show up FTG uptake along the potential risk sites. But I'll go through that in a minute. This is a more recent paper published in May 2025, predicting the risk of pathological fracture. And they also came to the same conclusion that Miral system, most commonly used based on X-rays, has good negative predictive value, but the specificity is low. While this the CT-based systems are technically challenging. They improve on specificity, but they have their own challenges, and their availability it's not like a one-button thing within the CT. These require complex procedures as yet. We don't know. In near future, we might be seeing something really fantastic with AI and all that, if these things can be incorporated into standard CTs. But at the moment, the advantage of specificity is limited. And this paper is from 2025. The previous two papers that I showed you were around 2021 review articles. So essentially from 2021 to 2025, there's consistent evidence that Miral is good, but it has with some serious limitations of specificity, while the CT-based systems are robust, but there are technical challenges with it. Now, getting on to the second step with the risk fracture assessment is, what's the impact? The impact is that, a patient who has a high risk metastatic lesions, if it's prophylactically fixed, it has an impact on the clinical outcome of the overall critical outcome of the disease and the patient survival. That's the clear thing. So that's critical, the burning question. Let's pick up the right lesions to fix prophylactically. That's very important. Same here, the survivor advantage, and there are multiple studies on that. If the clinical decision-making tool is robust, they're able to identify the cases which will be actually, in which case it will be helpful to intervene and fix it internally. They should be identified. It has an impact on the resources, and of course the outcome. It has an impact on overall survival, and it has an impact on the what you call subsequent complications of one, because fracturing a femur has got a lot more impact on day-to-day move activities as compared to a fracture of a rib. Now, this is another paper in which the outcomes of intermittently nailing between an impending and completed fracture were actually compared, and all these demographic factors and different other factors were sort of not so significant. But what was significant, the femoral fracture has much greater impact, and a timely intervention and nailing of the femoral metastasis has an impact on post-op survival and gait function and less loss of blood and shorter duration of surgery in hospital stay. So it's a multidimensional. So weight-bearing bone with a metastasis requires timely intervention, which requires a good screening tool to identify which patient needs intervention and which does not. Pathological fracture and the impact on resource utilization. This is a good study done across 8 European countries in which they looked at the skeletal related event, how it had an impact on the cost of the treatment. And as one would expect, it was visible that the number and duration of inpatient stays from pathological fracture of long bones was more as compared to the non-long weight-bearing bones. So again, identifying those, lesions which can be best treated with timely fixation is important. This is a recent paper, which actually, the title actually are we underestimating pathological fracture risk in malignant bone lesions of the proximal humerus. The title is focusing on humerus, but to get to this answer to this question, they actually looked the entire data. And the reason for focus on humerus was because within the myral system, there's a higher score for a trochanteric lesion, lesser for femur, and the least score is actually for a lesion in the humerus. So in this study, when they looked at all the 251 patients who actually had fixation for the metastasis, they could see that, in clinical presentation, most of the patients had unstable fractures, almost 60%. In 31%, pain was the main presenting factor. Well, then there were other factors as well. In the anatomic region, lower limb was the most commonly affected, followed by upper limb. However, it still constitutes 30%. So this actually highlights that too much focus on actually just the lower limbs is not sort of very helpful. Within the bones, femur was like 54%, followed by 25% involvement of the humerus. So that's how this paper addresses that, where are we with the identification of involving of metastasis in the humerus. And within the A-long bone, the proximal end was the most common site, followed by the proximal shaft, and the number sort of frequency reduces as we go to the distal end. So proximal femur and the proximal humerus are the sites of concern. In their conclusion, they actually showed that most of, in the initial pie chart, we saw that patients present with fractures, but then the second most common factor was pain, which actually led to the diagnosis of metastasis in the long bone. The no pathological fracture group either had a proximal femur fracture or some other fracture, while the humerus lesions were mostly picked up as pathological fractures. And this was happening because, like in the CT scan, the arms are up, and somehow probably in their bone scan data as well, arms were not included. So it basically, humerus was not being part of any workup, of most workup, as compared to definitely the lower limbs are involved. So the two most common regions for orthopedically relevant bone metastasis in the extremities are the proximal femur and proximal humerus. Lesions of the humerus are less frequently captured in standard staging diagnostics, and thus additionally they get a lesser score on the myral scoring as well. So they can go unnoticed until fractures occur. So that explains why the focus of the article was on humerus. So there's more emphasis that actually humerus also needs to be considered at the time of evaluation. This is again a paper from, so this is a slide which I actually showed you earlier. So this was again, this was like myral scoring of high score compared with different CT options of looking at the cortical bone lesion. And basically I put the slide here to put this red box, think about the bone spec CT. Since we're talking about the bone and we're looking at X-rays and CTs to evaluate the risk assessment, now once we start thinking about spec CT, we are bringing the focus from a whole body bone scan to a focused spec CT of a bone metastasis. Now, this is a study, fortunately, I was part of this, which was done in the Cancer Center in Lahore, and we looked at the bone spec CT and the authors proposed a modified Marl system incorporating the SPECT-CT. And here you can see table 1 is about the Marl scoring system, so in which we actually have got 4 criteria: site of the lesion, pain, the grade of pain, lesion, this composition as based on the X-ray, whether it's blastic or lytic predominantly, or the size as assessed by the X-ray, whether it's involving less than 1/3 or more than 2/3 of it. So the authors came up with a modified Marl scoring system, which was SPECT-CT based. While the site, it was not touched, it remained upper limb scoring as 1, and the pituitary as 3, and lower limb in the middle. Pain again, mild, moderate, functional, same category. The lesion, which was assessed as blastic or lytic based on X-ray features, in this study, it was based predominantly as blastic or lytic, based on the avidity. It was visual analysis on the MDT avidity. Again, for the size, while in Marl's classical, it's based on X-ray, here it was based on axial CT, involving the 1/3, less than 1/3, or more than 2/3. So that was the modified criteria, and these are the 2 additional features. So that was a modification to the model class. Now, the results were very promising. It's just a pilot study with like limited patients. In the extramural score, the less than 7 score was in 5 patients, which improved to 8. So what was looking as lytic actually turned out to be sclerotic in few lesions, and the other factors remaining stable. Then they also incorporating the extent of the lesion. So where we had less than 7 as 5 on X-ray based, it became 8 on SPECT-CT based. In category 8, there were 15 patients, and again 15 in the SPECT-CT. However, there had been a shift, because in the greater than 9 category, there were 12 patients and they became 9. So there was a shift from what looked like high score became the midline score, and from the midline, it became the less than 7 score. So it had an impact on bivariate analysis. This was statistically significant. And in one of the papers earlier mentioned, Demeron et al. Reported the treatment dilemma is mostly around score 8, because less than 7 get treated conservatively and greater than 9 go towards internal fixation, or but it's basically around score. So that's where actually the authors found the SPECT-CT could actually be of benefit. So, and additionally, cortical lysis was noted in 8 cases by SPECT-CT versus 2 on X-ray. Additionally, SPECT-CT parameters were involved. They showed circumferential involvement, and in some cases, also the extraosseous soft tissue could be identified. So we also got other benefits of CT when we incorporated SPECT-CT in the Marl scoring system. This is the paper which was mentioned in one of those earlier papers, in which Gary and team used actually FTG to assess the risk of fracture, and they essentially concluded that the total glycolytic volume and a cutoff of 81 could be, the defining point above which there was a high risk of fracture and below which there was the likelihood of less fracture. So the total lesion glycolysis could be a cutoff utilizing FTG for risk assessment. This paper has been quoted in review articles, but I could not find any more further articles with the use of FTG to look for risk stratification. So in this paper, when the new decision-making tools for prophylactic surgery were reviewed, these 2 papers are quoted: bone SPECT-CT, the modified material classification, and the FTG PET-CT. So basically, from this slide, what I'm trying to tell you is that the team which has to decide on intervention or no intervention is reviewing the data coming from the imaging colleagues, and they are looking at the new things that we are able to offer in the light of what is already available. Now, this is a very recent article published this year in Cancer, and they have looked at the advancement in assessing pathological risk fracture, news on the Marl score. Now, as Marl score remains the most commonly used X-ray based mechanism. They have reviewed the literature from 2003 up till 2004, and these papers at the top actually essentially there are different cohorts in which the model scoring system was found useful, or its limitations were actually evaluated, and observations, consistent observations made by various teams. In the middle of this list, they actually, around 2018, they mentioned this paper about SPECT-CT, in which the modified model score system was suggested as a pilot study. Further down after 2018, there are papers which is talking about the finite analysis and the rigidity analysis done on CT, the promise that these options offer, and of course their limitations as well. In the conclusion, they look at all these things as good, and they are hopeful that there was, however, when you look back from the data from 10 years, nothing new has come up. It's basically in the last 5 years, nothing new has come up. In one of the conclusions, in the conclusion, they actually mentioned that the use of advanced technologies such as CT rigidity and technetium MDT SPECT-CT offers a more accurate approach for fracture management. That's very promising. However, their accessibility remains a challenge, as they are not readily available to all patients. Now, I've sort of, when I looked at this conclusion, I thought, well, it's true for CT, because the CT rigidity analysis is not readily available at the moment. It will get, more accessible and easier to use and apply as well in due course. However, bone scan is pretty readily available. I cannot think of an oncology system or a setup which would not offer bone scans, and every camera offers a SPECT. Most places have got SPECT-CT already, and if there's no SPECT-CT, then of course a SPECT can be done and incorporated into a, fused with a CT scan. So this option, if there's so basically what needs to be done is that, since bone SPECT-CT with or without CT is available, we need to look more into this, idea, and of course the technique and the outcomes need much robust validation, and then probably marketing. So because bone scan is available, that's the the simple message out of today's talk. So we all know that the global incidence rate of cancer is projected to increase. Newer therapies are showing longer survival with and without with metastatic disease. Patients at risk of fracture need to be identified. There are treatment options available to minimize their risk of fracture and sort of have a positive impact on their mobility and overall survival from these malignancies that any individual is facing. And without good tools to identify impending fracture, the potential remains for unnecessary surgeries, because there's resource limitation, there's time limitation. If the patients who could have done better without surgery actually get onto the operating tables, and the ones who actually need operation will be left outside. So the robust tool and the review articles that I've shared, a few of those that I was able to share in this talk, actually clearly shows that the orthopedics and other oncology teams are looking for a robust tool, or the current tools to become more robust. And in that sense, the view is that nuclear medicine can offer these tools. First, we do whole body scans, total body scans with PET or conventional imaging. So that's one edge that nuclear medicine imaging offers. And then secondly, if we focus on the fracture risk assessment with the modified Myrle's criteria, the features of CT which are coming up, like rigidity analysis, even when they come in, they can become part of the SPECT-CT as well. So the molecular or the metabolic or the nuclear component of imaging of the metastasis is critical. To me, this is classical theranostics, a diagnostic tool which actually helps direct treatment options. This is a little different from what is the most fashionable theranostics we have these days. So that's about it. I'm happy to take any questions. Thank you.
Thank you very much, Dr. Humayun Bashir, for a very insightful talk with a very, very thorough literature review and very enlightening. So I have one question from Dr. Josna Rao in the chat. She said, excellent talk. Are there any F18 PET-CT data?
The paper, the only one paper that I could find with FDG was with Gary and team done in US, in which they looked at the glycolysis volume, and they had a cutoff of 81, which can differentiate between. I actually I didn't come across, and that's the paper which is mentioned in the reviews as well. But I think, because you see what is happening, that normally in our day-to-day clinical reporting, whenever we see a bone metastasis, and most of the care, of course, is multidisciplinary, and even if when it is not, any individual who is reporting a PET scan or a bone scan uh, will actually highlight that this particular region is at risk of fracture, and then sort of start that. The mention of the risk is almost pretty common in all good reportings, so it sort of gets sorted in that sense. The focus, I mean, just imagine that this viral score has been there for like over 3 decades now. There is a need, and these papers in the last 5 to 7 years actually highlighting the need now. So we need to do more papers, as this question says, about FDG, and maybe PSMA as well, and of course HDP and MDP. So work needs to be done. So that's why I titled it. It's a very nice question. It's a less traveled road. It's there. The tool is in our hand. We mention it in our reports. This looks like a high risk lesion, but we haven't actually made it a formal scoring instrument to give the clinicians a risk assessment.
Thank you, Dr. Humayun. And I think Dr. Josna also was mentioning F18 sodium fluoride.
Oh, yes. Yeah. With sodium fluoride, it's wonderful. It's very expensive method of doing bone scan. I think with sodium fluoride, like the places that I have worked, there was never enough time we could stop doing FDG and start doing F18 bone scanning. And mostly the cheaper conventional bone scan was available. But yes, of course, if HDP is good, MDP is good, then F18 fluoride would also be equally good.
Yeah, and I agree. There's always a challenge in busy oncology practice to accommodate non-oncology patients.
Yeah. I think the best time was around when there was COVID, and the supply of technician was out, and cyclotrons, because they were locally available, they did some F18s. But F18 has not become, fluoride has not become the common tool. It's unlikely to replace. It's very expensive.
Yeah, and even in US, we were using it under NOPR, which is National Oncologic PET Registry, and then that was withdrawn because that was primarily truly for bone metastasis, not for anything else. I think Alavi's group has done a work about sodium fluoride and atherosclerosis and all those, but not for fracture risk assessment.
In our practice, we're using it mostly for benign conditions like F18 bone, like facetal arthritis, such things. But mostly because the neurosurgeons, they send it and we identify it very well because of CT, and then they inject those areas. But oncologic, it's all FDG PET.
Yeah.
And our MDP bone scan numbers have gone down for skeletal survey, with FDG becoming more popular.
Yeah. Oh, exactly. One of the ideas behind this concept of doing a SPECT CT for risk fracture is that as the need for basic whole body scan with MDP or bone pressure goes down, we need to diversify our utilization of SPECT CT. And this, if we are giving more information on, say, risk assessment, that's another way of, what we are losing in terms of doing bone scans. We become more specific for bone scans. The same like, we doing bone scans for prosthesis. So we specialize in the application of bones SPECT CT.
Very well said. Dr. Humayun, going back to your paper from 2018, so when you did that, did you use it as a clinical practice at Shakothanam, or was it?
That was a pilot study. My understanding at the moment, they are doing the studies on, because that was a pilot and we liked it, and the results were initially so promising that we discussed and actually published it at that time. At the moment, there's an ongoing prospective data collection on it. It's a busy oncology center that they can get the right cases and actually trying to see whether these results can be validated in a larger cohort.
Okay, sounds good. Thank you. Any other questions from the audience? Seeing and hearing none, I would like to wrap up and thank you very much, Dr. Humayun, for your talk. Very well appreciate your, the insights about the, the non-oncology aspect of bone scintigraphy. And I thank all of you who attended the talk, and this talk is recorded and you can see it on the website. It will be posted shortly in a day or two. Thank you.
Thank you.
Thank you very much, Dr.
Thank
Bashir.
you. Thank you.